obligatory disclaimers I have to make. We're going to talk about some really rough and graphic calls. That's a trigger for anybody, just be forewarned. And this is more of an excuse for me to swear, but there will be some graphic language in here as well. So, just so you guys know. Before we get started here, Dr. Charlie Bortle, the man you see on the screen here, passed away earlier in October after a battle of cancer. He was one of those dudes who did just about everything he could in EMS. You didn't get very far in EMS in Philadelphia or Pennsylvania without at least knowing his name. I worked with him as a critical care educator for a few years, and with his passing, I just wanted to ask if everyone would just take a moment of silence and then we can get started. Awesome, thank you very much. All right, so let's hope that cursor goes away. All right, is that it? I'm James Boomhower, and I am going to talk to you today about fitness for duty and mental health in EMS. Mental health in EMS, specifically for those of us on the critical care transport side of the coin. Can you all hear me okay without me being too close to the mic? Okay, quiet's never normally a problem for me, but it helps to ask. I have some contact info up here if anybody wants to keep in touch afterwards. There's a number of different ways to do it, and I'd be happy to talk about it. I have no disclosures to announce to you, and I will sort of pseudo-lean against the lectern and be close to the mic. I want to start this talk by telling you guys how A-okay I was. That super slim, freshly shaven, really young me is the obligatory Boston Med Flight off orientation, you now have your wings picture. That's Flat Stanley above him, for anybody who's curious. This is the picture that you can finally put on Facebook, that you can finally show people that you're not just some dude who's trying to get through orientation, but you're actually a critical care transport provider with this system. Many of us work in this field already. We all appreciate the significance of getting your wings. I was 28. I'd been in EMS for about 11 years. I'd been a paramedic for 10. I've been a paramedic in New York, Maine, and now starting in Massachusetts. And while I in no way, shape, or form mean to alliterate that I knew what I was doing, I had a good foundation of EMS. I had a really good family structure. I had great friends. I had a ton of support from where I came from, where I used to be, and I was in the middle of an amazing relationship with a beautiful young woman who was also slaying her professional career, right? We were rocking the 20-something professionals just going on with the world. So I walked around every day like I had a castle. Like I was on point, didn't need anything from anybody for any reason. I had my team, I had my network, I had all this stuff put together. In the event that I was challenged or the event that I needed help or support, I had it. There's even alligators in there, like that's real. That's a genuine castle, real things, right? All put together. The call that precipitates this talk comes out of the Lawrence Municipal Airport, which is about an hour and 20 minutes away from my home. To add to that castle, I'll tell you that I was working with a rock star pilot, just a super nice dude, really good at what he did. My nurse was a 15-year critical care veteran and a practicing nurse practitioner in Boston. She could do this job with her eyes closed, and I was the decoration that occasionally carried the bags. Right, my role in this team as far as autonomous healthcare provider to make the decisions, yes, James, we should open the airway. Like that's where we are, right? Nothing too terribly complicated, which further boasts my, we're all good in the hood, everything's fine. Later that day, we get a rota request for a 34-year-old male with a GI bleed. Now, regardless of license level, the clinicians in here should think two things. That is super young for a GI bleed. And on the critical care side of the coin, I'd expect to see more. 34-year-old GI bleed, Blakemore tube, octreotide, blood, hep block. Give me something other than a GI bleed. And I'll leave any disparaging comments on comm specs out of the equation. I choose to believe that that was what they got and then somebody hung up the phone. Right? So here's what we got to do. Boom, hang up the phone, and we're off. We walk in to XYZ Hospital, And the first thing I notice is the physician is maybe a year older than me, which is alarming because they went to medical school, right? I got my degree in paramedicine, and then I got my bachelor's, and now it's now, and that's real, and I'm not taking away from it, but they've completed medical school training. And it's day 2 as a standalone physician in this teeny tiny little emergency department, way, way out of the way. And just as nervous as I'm talking to you, this physician comes up to us, hands trembling, with really sweaty notes, and says, "Oh my God, I'm so glad you guys are here, I really need your help." Cool. Literally our job, happy to do it. How can we help? My nurse goes away with him, gets report, I pull back the curtain, and I see this. Chaos. There is blood hanging but not primed. There's vasoactive medications and saline infusing onto the floor because someone broke the manifold of the triple lumen and nobody saw it. So I'm literally squish, squish, squish as I walk in the room, and people think that there's 20 mics of Levophed hanging and there's liter 3, and we have no idea where anything is. And people are in an absolute tailspin as this guy, my size but bigger, right? A little bit taller, a little bit wider, way heavier, is sitting on the stretcher, struggling to breathe, white as the walls that surround us, trying real hard not to die. There's a number of people here that know me, that have worked with me, that have met me. First thing I did, "Hey, I'm James, I'm a paramedic with MedFlight." Right? It's my first thing. "Hi, how are you?" All right, kind of weasel my way through the nursing staff, plop my monitor down, and I go to shake my patient's hand. A, it's nice. B, it kind of reminds everyone that we're talking about humans. And C, if you want to be super fancy, you can get a neuro assessment done. So their eyes lock with mine. Do they have the proprioceptive awareness to reach my hand? Is there any strength in that shake? What's their skin, color, temperature, and condition, right? I can get a lot from that with what just looks like a simple handshake. What I get is a delayed, kind of glassy stare over to me, a limp, ice cold, dead white extremity that reaches mine, and dead fishes, right? Nothing, no squeeze. And this dude, I mean, he would shake your hand. And he says, "I really, really don't feel good." I believe it, you don't look good. That's a fair assessment. Talking to the staff, trying to ascertain what's gone where, do they know the manifold's broken, there's fluid on the floor, and I look up at the monitor and I see this. I don't love it, but I don't hate it. And as I'm talking to the staff, I say, "So how long have you had that belly pain for, sir?" "Sir, can you hear me?" There's a problem when people don't know how sick someone is. When you don't know how sick someone is, you are not ready for them to die. So a staff who saw this man 3 hours before walk in, "Hi, my belly hurts, I've been pooping some blood, my wife won't get off me, I'm just gonna go get checked out, and then we're gonna take our kids to the movies." Like, this is just part of the Saturday. The room that was chaotic imploded. Chaos. We were trying to defibrillate with defibrillation paddles that were plugged into a different machine. One person was running a life pack, I was running a Zoll, and I eventually cut the wires on the Zoll so no one got hurt because everyone was trying to charge and defibrillate at the same time. No one's coordinating CPR, someone's trying to hang blood that hasn't been primed yet and is trying to do all this and that. My nurse walks in, and picture it, right? "I left you alone for 2 minutes, and he's dead. What did you do?" And I am coming unglued because my specialty is people and situations. It's all right, dead is fine, we all know how to work with dead, I need you to restart CPR, I need you to do this, I need you to do that. None of that. I have one person doing compressions every other minute, I have somebody squeezing the bag of the LMA that they put in, it's a mess, it's all over the place. And this very calm, very confident, very quiet woman goes, "Everyone stop and look at me." And I just came off orientation, so I lockstep like this, because that's what I've been doing for my entire career. And the entire room diverted their attention to her. All she did was pull the train back and put it on the tracks. Okay, you start CPR. You bag asynchronous with compressions. We don't need to worry about that right now. You, why is there fluid on the floor? James, I need you to prime blood. I need this, I need that, and I need the doctor in here so we can keep working on some stuff. Right? That's that 15 years of experience coming together, right? I'm trying real hard to successfully complete each individual task, and she sees that I'm A, not successfully doing any of that, and B, that because of that, I'm furthering the tailspin. Now, to help illustrate how stressed out I am at this point, I've successfully transfused a unit of packed cells into the normal saline. At least the giggles mean some of us have been there, right? Why is the saline turning pink? Oh, don't worry about that. Just because roller clamps are complicated for a critical care specialist, I suppose. Not confidence inspiring, right? I walked in and said, listen, I was 28, I had my shit together, I've been a medic for a long time. They don't give blood in New York, do they? No, they don't. So that's new for me. We are now about 30 minutes into the code. And one of the nursing staff at the Standing Hospital says, somebody should really let his wife know what's going on. Because the last time they talked to the wife, which was about 90 minutes before MedFlight got there, it was, he's way sicker than we thought, but he's going to be okay. We're calling the transport team. They're going to take him into Boston because we can't do the procedure here. Simple. So she canceled her movie tickets and sat there. Still no big deal. I knew he wasn't feeling well. Nobody should poop blood. Everything's fine. The only person that didn't know how sick he was more than the clinicians was his wife. So imagine you're an hour into your resuscitation, right? Because we had a minute or two there where he wasn't super dead yet. You're trying to get all this stuff squared away. You're trying to recoup all these people. You're quickly realizing that your command of that GI hemorrhage protocol and blood transfusion protocol that you thought you had on lock, no. That thing that I kind of vaguely scrolled through as we made our way to the hospital because I knew it. I just wanted to double check a couple little things because I know it, because I'm good, because I'm fine. Is deteriorating faster than I can shake a stick at. It's to the point now where I'm just asking for dosages, right? I'm an EMT again, with all love to my emergency medical technicians. Okay, I'll give that drug, what's the dose? Because I don't know. I am shook to the core. So you're his wife, and you walk into this. There is blood everywhere. Some of it is his, some of it is blood bank. There's saline, there's pressors, there's packaging, there's all of this. And there you sit, right at the head of the stretcher, screaming at your husband to wake up. You don't want to hear that. That's not something that you forget about or make fun of at the end of the call. Get up, we have to go, cut the shit, let's go. To her dead husband. We're an hour and change into the code now, and because we don't want to believe that we can't tidy this up enough to get us to Boston, to segue Vahe's talk on too sick for transport, right? I refuse to believe that I can't get 20 minutes. 20 minutes is what I need, and we'll get you into Boston. Can we fly the Boston GI team here? Maybe that'd be easier. Right? Refusing to accept that this 34-year-old man is dying, while simultaneously irate that the care before my arrival was subpar, which is super easy to say, right, when you get there. It's a lot easier to say it when you've seen it than to try to figure it out in the moment. So we decide that we're going to go for 15 more minutes for no other reason than our egos. Right? There is no, let's pour a little Pepto down the nasogastric tube and hope that that'll bind it up enough to get us anywhere, right? We're doing this for the wife. We're doing this for us. And if something happens, it happens. It didn't happen. It's always awkward when you do a lot of work as the transport team, right? It's in our name. We're the transport team, and then you don't transport. And it's not the, oh, we just had to pack up a couple things and be on our way. It's 30 minutes in the ER because I lost the glide scope. I don't know where the glide scope is. I'm sure it's in room 1, but I have no idea where it is. Trying desperately to package, square away equipment, try to figure out what goes where, what's the hospital's, what's ours, in almost dead silence. My partner, my pilot, and I express our condolences to the wife. We talked real quick to the sending facility. And that was about the only word spoke for the better part of 45 minutes. Equipment gets put back together, cleaned up as best we could. Our shift has long since ended throughout the duration of this call. So pack up, fly back home, do 3 hours of paperwork in the same infuriating silence, broken only by, so what catheter IV was that? What did we end up putting in? Was that a 4 element? Okay, that was it. And then we had this mandatory and nonsensical, you okay? We're all done, paperwork squared away, everything's set up and situated. You okay? What do we say? Yeah. Yeah, that sucked. We were all there. Yeah. Are you okay? Yeah. Okay. It's important for me to take this moment, and this is not a dig at any of the managers or supervisors here. That "are you okay" from my partner at 3 in the morning was the only time it was asked for 3 weeks. First email I got from my agency, you forgot to sign the flow sheet. When you get back in, if you can sign that, that'd be great. 2 weeks and 5 days went by before somebody said, whoa, I just read this, are you okay? I leave the highway up here because now I have an hour and 20-minute drive home. It's a lot of thinking time, right? Call's done, I'm done, my partner's done, we're all done. And all I want to do is talk to my girlfriend. Big part of that castle. 305, no answer. 307, no answer. 308, no answer. 311, no answer. Pick up the fucking phone! We all know that the phone just vibrated off the nightstand, right? Like, it's 3 a.m. and she's a human, so she's asleep. I make it home, mad at the world. I grab a bottle of my favorite whiskey, I drink what was left of it, and I wake up the next morning, face down in a blood-covered flight suit, holding the bottle by the neck. To 7 missed calls from my girlfriend. Oh my God, I was asleep, are you okay? What's going on? I called her back and said, yeah, it was a rough call. I'm sorry I bothered you so late. Not, oh, not okay. Nope, not okay at all. Need a day. Not, I'm just mad about it. Not, I want to talk about it. Just that typical EMS bravado bullshit of rough call. Not another word spoke. What does she do? She's not an EMS. Okay, it was a rough call. I got it. Those suck. You've given me nothing else to help you with. So there I lie. All this did was show me little teeny tiny cracks in that castle. And as I sit looking at those cracks, I have the choice to throw more spackle on it, right? More whiskey and playing it off like it was nothing. Or I can take just a minute and look a little bit deeper and make sure I'm not missing anything. And when I actually took a minute to look at those breakdowns and what was going on, I didn't have a castle at all, right? I had paper mache'd a whole bunch of falsities together, thought I was fine, told myself I was fine, made it through some stuff, drank a lot of whiskey, and was totally okay. I appreciate that spackle is easy. I appreciate that the patches that we use are simple and they work in the short term. But if I just kept throwing patch after patch after patch on what was actually going on, eventually this whole structure would have fallen down regardless. And I give you this whole story today because one first responder will commit suicide every 4 days in the United States. Some of us have shifts that are longer than that. One of us is going to commit suicide every 4 days. By taking the time to do it the hard way, by taking the time to call the numbers, to utilize the FAST team, to talk to somebody about this, and actually fix it, we can start to bring this number down. And what I want all of you to take away from this is I want all of you to treat your mental health no differently than you treat the physical health of your patients. Everyone here, as I was telling the story about the GI bleed, and you're all lying to me if you didn't, started their own narrative of how they would have treated that patient. Oh, well, it sounds like we should have done this, and let's fix the manifold, and let's go with this, and what unit of packed cells are we on, and have we got any plasma? And we all start to work through that because I painted you a crystal clear picture of a super sick dude who walked in sick, showed all the symptomology of staying sick and getting worse, and no one did anything until we arrested. How many of us have a loved one, a partner, a friend who commits suicide, and we all said, they were pretty down the other day. They've been getting real mad at work lately over some silly stuff. If we take the time to rebuild those walls and to actually look at what our own walls are, we can improve this for one another, we can improve this for our teams, and we can be healthier overall as a profession. There isn't anyone in this room that doesn't know what to do for this arrhythmia. Career, license level, whatever. Everyone here knows how to manage that. I want you to take the same intensity and the same wherewithal to treat this the same way. Thank you for your time.